So this is the complex congenital heart defect section. And we're going to look at the transposition of the great arteries. Now, you have to remember what the normal anatomy is for you to fully understand what we mean by transposition. So when we talk about transposition of the great vessels or the great arteries, the great arteries of the aorta and the pulmonary system, the pulmonary trunk, and the aorta, those are the great vessels. When we have transposition, when we talk about transposition, something is out of position, okay? So it's an abnormal spatial arrangement of the pulmonary artery and the aorta. So they are out of position. They're not in their normal position. So, but I'm going to give you a very simple way to understand this. So we have two types of transposition of the great arteries. And in the literature, you'll see it as TGA. You have the dextro and the levo. So, so you have the dextro transposition of the great arteries and then the levo transposition. So, all right. So let's look at the dextro transposition. So again, when we say transposition, it's out of its normal position. We're gonna really simplify things. When we say detransposition or dextrotransposition, what happened is the ventricles are in their normal position. So the ventricles are in their normal position, but what you have is the great vessels. The great vessels are switched, if so to speak. Okay, so instead of the right ventricle pumping blood into the pulmonary circuit, the right ventricle is going to pump blood into the aorta. Okay, and then instead of the left ventricle pumping blood into the aorta, the left ventricle is going to pump blood into the pulmonary circuit. Okay, so that's a major problem. So think about it. That's a major problem. With the normal circulation, you're supposed to have the deoxygenated blood in the right side of the heart going through the pulmonary circuit to the lungs, where it's oxygenated, and then it travels via the pulmonary veins to the left atrium, the left ventricle, and then out through the aorta with rich oxygenated blood. But in detransposition, the vessels are transposed, they're switched. So the deoxygenated blood on the right side of the heart is going to pump blood into the aorta. So the aorta is going to receive deoxygenated blood. The body was not designed for that type of thing. And on the left side, the oxygenated blood is going to go through the lungs. So it's going to be a circus. I mean, it's not going to achieve any good. So individuals with or babies who are born with detransposition, they cannot survive unless you have some mixture of the oxygenated and deoxygenated blood. Okay, so a lot of these babies are, if they survive, they have a shunt, and that's the only way they can survive. So this is what we This is what we just described. So the right side, you have the right atrium, and the right atrium is going to receive blood from the superior vena cava, inferior vena cava. That's deoxygenated blood that is flows into the right ventricle, and then it's going to come out through the aorta, and then it's going to go, it's going to become systemic blood. That's not really compatible with life unless there's some admixture. And then on the left side, you get the pulmonary veins draining to the left atrium, the left ventricle, and then through the pulmonary circuit to the lungs. So it's going to become oxygenated again, and it's going to come back. So that's not going to achieve anything. So this is detransposition. And you can see that there's tremendous amount of problem associated with this. If somehow you can get oxygenated blood into the right side, then this individual can survive. Because remember, the brain and the different tissues, they need oxygenated blood to survive, okay? So when you do your echo, and remember, you have to remember your normal anatomy. So if you get an abnormal anatomy where in the parasternal long axis view, if it's the aorta somewhat above the pulmonary artery, then you start thinking, and then you have to look at the whole heart. Okay, you have to look at the whole heart in its entirety. So when you do your 4-chamber view, you will see that the 5-chamber view, to be exact, you will see that the left ventricle is pumping blood into the pulmonary circuit, and not only the vessels are transposed, but the position is also abnormal, and you can recognize this on the echo as well. So your short axis view, your parasternal long axis view will sort of tip you off. And again, if these individuals are going to survive, there have to be shunts. So you have to look for the shunts. Okay. When we talk about L transposition now, this is a much easier. So how I think about, with D transposition is the vessels that are transposed. With L transposition, just think in terms, the vessels are in the correct position, but the ventricles are transposed. What we mean by that? So on the right side, you're going to have the left ventricle, and on the left side, you're going to have the right ventricle. So on the left side, you're going to have the left ventricle pumping blood into the pulmonary circuit, because just the ventricles are transposed. The great vessels, they're in their correct position. So your anatomical left ventricle is going to pump blood into the pulmonary circuit, but it's going to be deoxygenated blood, because the deoxygenated blood is going to flow into the right atrium and then into the anatomical left ventricle, which is going to pump blood through the pulmonary circuit. On the left side now, you're going to have oxygenated blood coming from the lungs via the pulmonary veins. They're going to oxygenated blood is going to travel into the left atrium and then into the anatomical right ventricle. So the right ventricle is going to get the oxygenated blood, and it's going to pump blood into the aorta. So oxygenated blood is going it's going to go the right direction where it's supposed to go. Deoxygenated blood is going to go where it's supposed to go. The problem, though, is the right ventricle is not designed to 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 pump systemically. It is not designed for the pressures on the left side. So usually, if these patients are not identified early, then they're going to present with heart failure because the right ventricle, remember, the right ventricle, thin wall, the tricuspid valve is not as sturdy. So they're going to present with heart failure, significant tricuspid regurgitation, and the right ventricle is going to fail because the right ventricle is not designed to pump systemically. Okay, so again, just detransposition, you just transpose the vessels. Okay, the ventricles are in the correct position. With L transposition, with detransposition, you transpose the arteries, just the great arteries, right? Just the great arteries you transpose. With L transposition, just the ventricles are transposed. And just remembering that, you can work out the problems. Those of you who work in the echo lab, you realistically, if you see a detransposition, that patient have a shunt. That's the only way they can survive. You can see L transposition. You can see L transposition because you might see them when the right ventricle fail and they're in heart failure. So the doctor may send the patient to the lab because they're in heart failure, and you make your assessment. Or if it's a young individual, you can pick them up before the ventricle fails. So you're gonna have to rely on your old concept of the echo features of what distinguish right from left. Okay, remember, if you identify a tricuspid valve, that is the right ventricle. The tricuspid valve always leads into the right ventricle. So when you're doing your echo, one of the first things you're going to do is identify the valve which is lowest in the ventricle. The valve that's lowest in the ventricle is the tricuspid valve, and the tricuspid valve is going to allow flow to go into the right ventricle. So that will allow you to identify the right ventricle, and then the other ventricle will be the left, and you can figure out stuff and work out stuff. Okay. Now, as we said before, the deoxygenated blood in the L transposition, that is pumped from the right atrium into the morphologic left ventricle, because remember, the ventricles are transposed. So the left ventricle is now on the right side. And then the left ventricle is going to pump blood into the pulmonary artery and to the lungs. And then the oxygenated blood coming from the lungs is going to flow into the left atrium, and then in the morphologic right ventricle, which is now on the left side, and then into the aorta and the rest of the body. But again, the problem is the right ventricle cannot maintain adequate function pumping blood into the aorta. It's going to fail. The tricuspid valve is going to fail. Okay, so with your L transposition, things look good. Things look good because deoxygenated blood is going to the lungs. Oxygenated blood is going to the the tissues and organs and stuff like that. The problem, though, is this right ventricle, which is on the left side. The right ventricle is on the left side. It cannot maintain pumping blood through the aorta. So this is going to fail. You're going to have rip-roaring tricuspid regurgitation. Okay? So again, when you do your echo, the ventricle, the valve which is lowest in the ventricle, so your apical four-chamber view, this valve is lower than this one, so disidentify the tricuspid valve. The tricuspid valve leads into the right ventricle. And what you'll see is that the right ventricle is now dilated, ejection fraction is reduced, and you have significant regurgitation across the tricuspid valve. All right, so what we're going to do on Tuesday, we're going to go over cases. We're going to look at cases of these abnormalities, and so we can further understand what's going on, and we're able to identify we're able to identify these cases in the echo lab. So the take-home message is with detransposition, it's the vessels which are transposed. The great arteries are transposed. The aorta and the pulmonary trunk. So they're switched. Okay? So the aorta is going to be on the right side. The pulmonary system is going to be on the left side. If you don't have mixture of the blood, if you don't have mixing of the oxygenated blood going to the aorta, that baby cannot survive. So if the baby survive, that means they have a shunt, either PDA or some shunt to survive. And then we have different type of operations to correct this, because if somehow we can get, because remember, it's just the major arteries which are transposed. The right atrium leads into the right ventricle, the left atrium leads into the left ventricle. So if somehow we could switch these vessels, we can correct the problem. So there are different type of techniques. You can do what we call an atrial switch. So if we transpose the atrium, so if we transpose the left atrium to the right side, then we can get oxygenated blood going to the aorta. But again, that's going to be fraught with problems later on. We can use conduits and baffles to sort of redirect blood. But we look at that when we look at the cases next Tuesday.